This recording will go over cirrhosis of the liver, why it is happening, and some complications that you will see in a patient with cirrhosis. Cirrhosis is extensive, irreversible scarring of the liver, usually caused by a chronic reaction to hepatic inflammation and necrosis. Cirrhosis is characterized by widespread fibrotic or scarred bands of connective tissue that change the liver's normal makeup and its associated cellular regulation. Inflammation caused by either toxins or disease results in extensive degeneration and destruction of hepatocytes. As cirrhosis develops, the tissue becomes nodular. These nodules can block bile ducts and normal blood flow throughout the liver. Impairments in blood and lymph flow result from compression caused by excessive fibrous tissues. Early in the disease, the liver is usually enlarged, firm, and hard. As cirrhosis continues, the liver shrinks in size, resulting in decreased liver function. Some patients with cirrhosis have no symptoms until serious complications occur. The impaired liver function results in elevated serum liver enzymes. So to summarize, cirrhosis is characterized by widespread fibrotic bands of connective tissue that changes the liver's normal makeup and its associated cellular regulation. Inflammation destroys hepatocytes and the liver becomes nodular, blocking blood flow and lymph flow throughout the liver. Common problems and complications associated with hepatic cirrhosis depend on the amount of damage sustained by the liver. In compensated cirrhosis, the liver is scarred and cellular regulation is impaired, but the organ can still perform essential functions without causing major symptoms. In decompensated cirrhosis, liver function is impaired with obvious signs and symptoms of liver failure. Cirrhosis and hepatic cell damage can lead to complications listed on the slide, including portal hypertension, ascites and esophageal varices, coagulation defects, jaundice, portal systemic encephalopathy with hepatic coma, hepatorenal syndrome, and spontaneous bacterial peritonitis. The first complication we're going to talk about is portal hypertension. And this one is important to know and understand and remember because it's the cause of many of the other complications that we're going to discuss. So portal hypertension is a persistent increase in pressure within the portal vein greater than 5 millimeters of mercury. It is a major complication of cirrhosis. So right here we have the portal vein, and with cirrhosis, with the changes in the liver, it makes the pressure inside this vein become higher. So what do you think happens with all this blood that's traveling from the esophagus, the stomach, from the intestines, the spleen that's trying to come in through the liver when this pressure gets elevated? It all ends up getting backed up, right? So the blood's trying to drain into the liver, the pressure's too high, so it goes back and it gets backed up. It results from increased resistance to or obstruction of the flow of blood through the portal vein and its branches. The blood meets resistance to the flow and seeks collateral or alternative venous channels around the high pressure area. So like we said, the increased pressure causes blood to back up. Blood backs up into the spleen, causing splenomegaly, which is enlargement of the spleen. It backs up to the veins of the esophagus, the stomach, the intestines, the abdomen, and the rectum, causing those veins to dilate. It can result in ascites, which we'll talk about in a little bit, which is excessive abdominal or peritoneal fluid. And it can also cause caput medusa, which is veins of the stomach sort of around the umbilicus becoming large and dilated, as well as hemorrhoids. So ascites is the medical term used to describe the buildup of fluid within the abdomen. Ascites is a collection of free fluid within the peritoneal cavity caused by increase of hydrostatic pressure from portal hypertension. So again, when I said that we have to understand the problem with that portal vein being hypertensive and everything else backflowing, that causes a lot of the signs and symptoms that we see with cirrhosis. The collection of plasma protein in the peritoneal fluid reduces the amount of circulating plasma protein in the blood. When this decrease is combined with the inability of the liver to produce albumin because of impaired liver cell function, the serum colloid osmotic pressure is decreased in the circulatory system. The result is a fluid shift from the vascular system into the abdomen, a form of third spacing. As a result, the patient may have hypovolemia and edema at the same time. Massive ascites may cause renal vasoconstriction, triggering the renin-angiotensin system that results in sodium and water retention, which increases hydrostatic pressure in the vascular volume, leading to more ascites. So we talked about with the increase of portal hypertension that blood can back up and cause hemorrhoids. It can also cause esophageal varices, which are in essence hemorrhoids of the esophagus. As a result of portal hypertension, blood backs up from the liver and enters the esophageal and gastric veins. Esophageal varices occur when fragile, thin-walled esophageal veins become distended and tortuous from increased pressure. The potential for varices to bleed depends on their size. Size is determined by direct endoscopic observation. Varices occur most often in the distal esophagus, but can be present also in the stomach and rectum. The main concern with esophageal varices is bleeding. Bleeding esophageal varices are life-threatening medical emergencies. Severe blood loss can occur, resulting in shock from hypovolemia. So remember, when you think of shock, you should be thinking of decreased blood pressure. In this case, the esophageal varices start bleeding. We lose blood, we're hemorrhaging from a varice or varix or varices. Hypovolemia occurs, which leads to shock, low blood pressure, not enough blood pressure to perfuse those vital organs. The bleeding can either cause hematemesis or vomiting of blood, or melena or black tarry stools. Loss of consciousness may occur before any observed bleeding. Variceal bleeding can occur spontaneously. However, any activity that increases abdominal pressure may increase the likelihood of a variceal bleed, including heavy lifting or vigorous physical exercise. In addition, chest trauma or dry, hard foods in the esophagus can cause bleeding. Patients with portal hypertension may also have portal hypertensive gastropathy. This complication can occur with or without esophageal varices. Slow gastric mucosal bleeding occurs, which may result in chronic slow blood loss, occult positive stools, and anemia. Splenomegaly, or enlarged spleen, results from the backup of blood into the spleen. The enlarged spleen destroys platelets, causing thrombocytopenia, or low serum platelet count, and increases the risk for bleeding. Thrombocytopenia is often the first clinical sign that a patient has liver dysfunction. In patients with cirrhosis, the production of bile in the liver is decreased. So normally, if you remember, the liver creates bile, which then can be stored in the gallbladder and eventually is deposited into the small intestine. The decreased production of bile in the liver prevents the absorption of fat-soluble vitamins, such as vitamin K. Without vitamin K, clotting factors are not produced in sufficient quantities, and the patient is susceptible to bleeding and easy bruising. Jaundice, a yellowish coloration of the skin, in patients with cirrhosis is caused by one of two mechanisms: hepatocellular disease or intrahepatic obstruction. Hepatocellular jaundice develops because the liver cells cannot effectively excrete bilirubin. Intrahepatic obstruction results from edema, fibrosis, or scarring of the hepatic bile channels and bile ducts, which interferes with normal bile and bilirubin excretion. Patients with jaundice often report pruritus or itching. Hepatic encephalopathy, also called portal systemic encephalopathy, is a complex cognitive syndrome that results from liver failure and cirrhosis. Patients report sleep disturbance, mood disturbance, mental status change, and speech problems early as this complication begins. Hepatic encephalopathy may be reversible with early intervention. Later, neurologic symptoms that include an altered level of consciousness, impaired thinking process, and neuromuscular problems occurs. Hepatic encephalopathy may develop slowly in patients with chronic liver disease and go undetected until later stages. Symptoms develop rapidly in acute liver dysfunction. The exact mechanisms causing hepatic encephalopathy are not clearly understood, but probably are the result of shunting of portovenous venous blood into the central circulation, so the liver is bypassed. And you remember that the job of the liver is to filter out or detox the blood. So as a result of the liver being bypassed, substances absorbed by the intestines are not broken down or detoxified and can lead to metabolic abnormalities, such as elevated serum ammonia and GABA, G-A-B-A. Elevated serum ammonia results from the inability of the liver to detoxify protein byproducts and is common in patients with hepatic encephalopathy. However, it's not a clear indicator of the presence of encephalopathy. Some patients may have major impairment without high elevations of serum ammonia. And elevations of ammonia can occur without evidence of encephalopathy. Factors that can lead to hepatic encephalopathy in patients with cirrhosis include a high protein diet, infection, hypovolemia and hypokalemia, constipation, GI bleed, and certain drugs. The prognosis depends on the severity of the underlying cause, the precipitating factors, and the degree of liver dysfunction. The development of hepatorenal syndrome indicates a poor prognosis for the patient with liver failure. It is often the cause of death in these patients. The syndrome is manifested by a sudden decrease in urinary flow, less than 500 mL per 24 hours, known as oliguria, elevated BUN and creatinine levels, with abnormally decreased urine sodium excretion, and also increased urine osmolarity. Patients with cirrhosis and ascites may develop acute spontaneous bacterial peritonitis. This may be the result of low concentrations of proteins. These proteins normally provide some protection against bacteria. The bacteria responsible for spontaneous bacterial peritonitis are typically from the bowel and reach the acidic fluid after migrating through the bowel wall and transversing the lymphatics. Symptoms vary but can include fever, chills, alteration in comfort, especially in the stomach or the abdomen, as well as tenderness. The diagnosis of spontaneous bacterial peritonitis is made when a sample of acidic fluid is obtained by paracentesis for cell counts and culture. Hepatitis C is the leading cause of cirrhosis and liver failure in the U.S. It is an infectious blood-borne illness that usually causes chronic disease and compromises the body's immunity. Inflammation caused by infection over time leads to progressive scarring of the liver, which impedes cellular regulation. It usually takes decades for cirrhosis to develop, although alcohol used in combination with Hep C may speed the process. Hep B also causes inflammation and low-grade damage over decades that can ultimately lead to cirrhosis. Hep D virus can infect the liver, but only in people who already have Hep B. Cirrhosis may also occur as a result of non-alcoholic fatty liver disease, which is associated with obesity, type 2 diabetes, and metabolic syndrome. It is the most common cause of liver disease in the world and can progress to liver cancer, cirrhosis, or failure, causing premature death. Another common cause of cirrhosis is excessive and prolonged alcohol use. Alcohol has a direct toxic effect on the hepatocytes and causes liver inflammation. The liver becomes enlarged with cellular degeneration and infiltration by fat, leukocytes, and lymphocytes. Over time, the inflammatory process decreases and the destructive phase increases as the ability to maintain appropriate cellular regulation decreases. Damage to the liver tissue progresses as malnutrition and repeated exposure to alcohol continues. If alcohol is withheld, the fatty infiltration and inflammation are reversible. If alcohol use continues, widespread scar tissue formation and fibrosis infiltrate the liver as a result of cellular necrosis. The long-term use of illicit drugs, such as cocaine, has similar effects on the liver.